My name is Dr. DiPaola, and I just started here a few months ago, but have been in practice doing orthopedics and shoulder and elbow surgery over the last 7 years. That's my specialty. Today I'm going to talk about rotator cuff tears, and it's an interesting topic. It's one of these entities that's extraordinarily common. I would venture to bet that everyone in this room has met someone who's had some kind of rotator cuff problem. But it's somewhat confusing, hence the title of the talk. And we'll get into why it's confusing. And I think people, when they hear about rotator cuff tears, I think they often try to assume that their problem is similar to someone else's problem, whether it's their brother-in-law's problem or someone else, to try and gain some firm footing in what they have. And I think that's one of the things that I deal with the most when I'm talking to patients about this problem, that it's very individualized, that you can have a rotator cuff problem far, far different than your friend's problem or your brother-in-law's problem. And there's a number of reasons why physical therapy alone or an injection alone may work for one person, but for someone else it may be a much more drastic solution that's needed. And that can be frustrating for people, I think, for patients. And maybe that's one of the reasons why you came today. Maybe you were confused too. But I know it's one of the things that I deal with when I talk to patients about these things, and why I enjoy doing these types of things, educating, because I think there is such a wide variation in rotator cuff problems, and it needs a little clarification. So go to the next slide. This is just a disclosure slide stating that I don't have any financial disclosures related to this talk that we are required to do with all of our talks now, but I don't have anything in particular going on financially related. This is purely educational talk. So next slide. Good, so background. Rotator cuff tears are the most common problem in the shoulder over the age of 40. So it's the most common problem I see in the office in patients over 40. And if you had to guess what someone has if they told you they had shoulder pain and they were over 40, it would probably be some type of rotator cuff problem. It's not always a tear, but sometimes it's just inflammation around the rotator cuff. And I think this is different than what you see in the knee or hip. And it can be confusing for patients because often the assumption is that it's arthritis. And those two things are actually quite different. And one of the reasons why we assume that arthritis is common in the shoulder, how are you?
Hey, how are you?
Okay. Is that knee and hip problems are much more common than shoulder problems, at least surgeries for knee and hip problems. So a typical scenario might be where a patient may go to their primary care doctor and they tell them that they're having a shoulder problem, and they say, well, it might be a little arthritis. It's a good assumption, around the knee or the hip, because it is so common in the knee and the hip. But it's actually two quite different problems. The knee and the hip are covered in the joint surfaces are covered in a thin layer of cartilage, much like the shoulder is. But the shoulder has a lot more of a muscular component to the stability and that's the function, in the sense that there are more things that go wrong with the rotator cuff muscles, and that's why we see that more commonly. So there's a wide variety of different types of, number one, treatments, but also the pathology involved with the rotator cuff. So when we say rotator cuff, we could be talking about far different entities from one end of the spectrum to the other. So you may have something as low level as just inflammation, which maybe an anti-inflammatory or therapy could help with, or it could be far worse. It could be that your rotator cuff tendons are all torn out of all four of them, that all of them are torn and not repairable. And there could be a very wide variation in the types of treatments you're talking about, from complex surgery to anti-inflammatories, and that's why it can be confusing. So the bottom line is, though, that there usually are good treatments for rotator cuff tears, but again, they have to be individualized. So let's go to the next slide. So 300,000, that's the number of rotator cuff operations that were done in the United States last year. And this isn't to say that they were all the same type of operation, because again, sometimes it's just bursitis around the rotator cuff, or sometimes it's merely that the rotator cuff is frayed. But 300,000, so it's a lot. And that would explain why so many people here know someone or have a family member that may have been affected by that type of thing. So it's a very, very common problem, and chances are that one of us, or all of us in some way, whether by ourselves or through a family member, will be afflicted with this type of problem, and it can come out of the blue. So it can be kind of disconcerting, because most people go along and live their lives, and they're not professional athletes, and they're not necessarily working as a laborer, doing drywall overhead or things like that, and they say, well, what is going on? Why am I hurting so bad? I can't get around the house and do normal things like I used to, like just reach in the cupboard. But the simple fact is that a lot of it just has to do with aging. It just has to do with that these muscles and these tendons that hold the ball and socket joint in the shoulder together and help them work, in time they change with age. And that's why you see it. So let's go to the next slide. So we've got a few distinct goals for this talk. So we want to definitely clarify some of these misconceptions. We'll talk a little bit about why there are these misconceptions, and we've gotten into that already, but we want to help you clarify that. The hope is that you come away at least with a glimmer more understanding of why it may be confusing to you, why someone else's rotator cuff problem isn't your rotator cuff problem at the end. And we want you, in the end, to come away with some actionable knowledge. In other words, there's going to be a lot of rotator cuff problems that will just get better with time. But then you'll want to know, when should I actually take action? When should I call someone and be seen or consider doing something, as opposed to just letting time take its course or trying to ignore it and let it go away? Because there are very specific times where action is good, and there's probably other times where if you let things ride and see if time takes care of them, that's okay too, because you don't want to intervene too quickly in many cases, when nature often has a way of taking care of itself. So I'm going to give you that point at the very end of the talk, and hopefully if you forget everything else, you'll come away knowing when you may actually want to be concerned and see someone, and when giving it a little bit of leeway will be helpful to you. So, and by the way, we've got a small group here, so I'm happy to, if people want to interrupt me during the talk, that's totally fine. I'm going to leave plenty of room for questions at the end. I've also got some bonus slides that I can get into, because I'm planning on talking mostly about what rotator cuff problems actually are and are not, and not as much about the treatments, but I left some extra slides at the end if you guys want to talk about that. But feel free at any moment to raise your hand, ask for clarification. The goal is to, as much as we can, help you with the information that you're seeking within limits. We can't necessarily answer super specific questions about individual cases, but we can talk in general at least, and so feel free. So, next slide. Good, so everybody recognizes these general activities. And these aren't, again, professional sporting activities. This isn't stuff that is super high demand that takes an athlete to do. These are just normal activities of daily living that all of us do to get around on a daily basis. But these are the things that I see people coming into my office complaining about. You know, when they have a shoulder problem, I hear the same complaints over and over again. And some of them aren't even on these slides. Sleeping is another one. For whatever reason, when you have shoulder pain, it's very difficult to sleep. So basic things, you know, buckling your seatbelt. I can't buckle my seatbelt. Having trouble reaching behind my back to grab my wallet. Can't reach in the cabinets. There's just, you know, basic stuff, and it can be extraordinarily debilitating. And I really feel for the people who come into the office, because you say, yeah, geez, this isn't You know, it's not like we're asking you to score a touchdown here, you know? So the thing is, though, that there's a lot of different types of shoulder problems. We're only touching on one today. We're only talking about rotator cuff problems because it's one of the most common. But you can get arthritis in the shoulder, and you can get shoulder instability, and you can have shoulder fractures and all these things. But one of the biggest things they have in common is that they tend to manifest in this same way. So anyone coming off the street who has a shoulder problem is probably going to have difficulties with some of these basic activities, which I think, again, leads to some of the confusion. You know, you say, well, you know, my cousin, she had the same thing. She had difficulty reaching behind her back, and she had difficulty sleeping. How come, you know, she didn't have to go through this type of treatment or that type of treatment? And we're going to get into a little bit about what makes the rotator cuff unique. But suffice it to say, when you have pain around your rotator cuff muscles, it causes trouble with all of these basic things. And it'll often prompt someone to want to come in and see me in the office. You know, these are everyday activities. So let's go to the next slide. So this one is where there's going to be the test at the end. So you've got to study up right now. No, there won't be a test. I would feel bad to do that. But so the rotator cuff. What is the cuff? Sometimes when we say the word, I think people get it mixed up, and they may either think it's a cup. So it's not a cup. It's not like a drinking cup. It's a cuff like a shirt sleeve cuff. So if you roll up your sleeve, and you see how your shirt sleeve cuff wraps around the end of your arm. Well, that's what the muscles in the rotator cuff do. So it's actually a group of 4 muscles, and if my hand is the ball and the muscles are my fingers on the other hand, what you have is 4 that almost completely envelope the shoulder joint, and they're the deepest layered muscles within your shoulder joint. They don't go a full 360 degrees around, but they do go almost 270 degrees around, and only this lower level beneath the lower part of the shoulder isn't covered by one of those muscles. So there's 4 muscles. They're helpful for not only helping keep your shoulder in the socket, but controlling movements around the shoulder. So the muscles you see on the surface here are bigger muscles. So you look at the deltoid muscle and the pectoralis muscle, the muscles you're seeing, you know, when the bodybuilders are doing their shows. Those aren't these muscles. These muscles are the next layer deeper. They're slightly smaller muscles than those, but they exert a lot of control on basic shoulder motions. So without them, you can actually end up in situations where the ball doesn't sit properly in the socket, and you have a significant amount of difficulty lifting your arm overhead, because they not only act to move the shoulder, they actually control this part of the ball. So their just normal everyday activity is helping this ball sit in the socket. And I want to talk about that point a little bit more, because I think it's different than other joints in the body. So if you think about another famous ball and socket joint in the body, the hip joint, that's really made up of a lot more bone than it is muscle, so to speak. Whereas the shoulder, instead of being cup-shaped, the socket part, it's more like a saucer. So think of cup versus saucer. So if you don't have all of these constraints, these muscles and other tissues, the ball could literally fall out of the socket. So it's important in that sense. So when we talk about rotator cuff, sometimes we use that word interchangeably to mean either the muscle or the tendon. Muscle, everybody knows what muscle is, but tendon's easy to forget, or if you never took anatomy, you may just not be tuned in. But tendon is this white tissue. It's the fabric. It's the fabric that connects the muscle to the bone. So you know that your muscles contract. You know, when you flex your muscle, you're doing work, and the muscle shortens. And that's what allows any of your skeletal system to move. Well, the tendon is that connective tissue. It's the stuff that's tying it in. Think of it like fabric or rope or whatever. So sometimes we as doctors, and that's why it can be confusing, we may use the words interchangeably. If I say your rotator cuff is torn or your rotator cuff isn't working. Well, sometimes I'm talking about the muscle, but sometimes I'm talking about the tendon. For your purposes, usually when we talk about tears, they're usually in this white portion, which is the tendon. And that's the part that, when we say age affects our rotator cuff, that's the part that's affected more in time. Because as long as that connection between the muscle and the bone is maintained, the muscle tends to stay active and strong. But once you lose that connection, then you get our enemy, atrophy. So it's the muscle can wither away. And that can be really hard to get back, and sometimes you can't ever get it back. So when we talk about tears, again, we're talking about this area here, the white tendon tissue. So as we all age, unfortunately, we become less flexible. Our tissues become less flexible, not more flexible. I think all of us probably recognize that. And in time, that can lead you to be more susceptible to either having a sudden tear, where maybe you fell and had a tear right away, or just having regular wear and tear. And the way I like to describe it is, think of it as the end of a rope, or maybe the bottom of your pant leg that dragged on the ground. If you think of any fabric type tissue, it has a thickness to it, and it can just get frayed. And there's a whole wide swath of variation within that. Any questions on this? Does this make sense to people? Because this is sort of the basis of, there's 4 different muscles here, but they have different levels of importance too, which is why, again, sometimes it may dictate your treatment, that one muscle is more important to fix than others. For instance, most common torn muscle is this muscle called the supraspinatus. It's the one that sits on top. But I would argue that the most important muscle is this big one here called the subscapularis, and that's in front. It's the biggest, but it also plays the biggest role, where if that one is gone, your shoulder usually doesn't function as well, where sometimes you can compensate for having a tear in one of the other muscles. So, any questions with that? Sure.
On your arm, where would the tendon be? In this end?
Right about where you pointed, kind of right here, but deep to the bigger deltoid muscle. So that's a really good point, that a lot of people, when they come into the office, they'll usually grab their arm. If they're having a rotator cuff problem, they'll usually grab their arm in this way. It's almost, you can almost predict it, that they'll say, they'll kind of use their whole hand and grab right here. So it's deep to that muscle, but sometimes you can even feel it if there's a separation in the muscle. You can even feel a clicking or a popping if there's a tear there. So. And then this is their shoulder blade. So everyone knows where their shoulder blade is, and those muscles start on the shoulder blade, but then they extend out like my fingers to grab on to the ball portion of your shoulder. So let's go to the next slide. So this slide here just demonstrates what a rotator cuff tear might look like. And while it's not perfect, it is a pretty good representation. The slide is showing, I talked about before, the big muscle in the front is called the subscapularis, and this is one of the most important muscles. Most commonly, you'll see a tear in the supraspinatus muscle. This is the muscle on top. You usually don't see tears in this muscle quite as much, but they do happen. But if you were to look at the one that was affected most often, it would be right up here. And that's right where we were pointing, kind of right on top of the shoulder, whereas the other one's right in the front. But it may look something like this, where there's actually a tear right in the fabric of the tendon itself. Usually what you'll see is the tendon lifted right off of the bone a little bit. But this might be considered a full thickness, but a partial full thickness tear. In other words, it's not the entire width of the tendon. And that gets to what I mentioned early in the talk, in that, how come, my friend had surgery, but you're saying I don't need surgery, and why is that? Well, the size of the tendon tear may dictate whether surgery is good for you or whether it's not, or the length of time, or those types of things. And as you can see, you can imagine that, imagine if you had a tear that started all the way at the bottom of this tendon and wrapped completely around. You'd imagine that person might have a far different problem than if your tear was teensy tiny right there, and it'll ultimately have an effect on what treatments work for you or whether there are even good treatments for you. The good news is that most, excuse me, out of all of those surgeries that we put up the big number of 300,000, most of them are not for big giant tears. So most are for either partial tears or small tears. And that's good, because otherwise we'd have a lot of really unhappy people out in the world that would be very, very difficult to treat. But the ones that are bigger are often more difficult to tackle. Thankfully things continue to develop in terms of technology and new surgical approaches. But that's one of the major factors that dictates. Now there's an interesting thing, and this is what always fascinates me about rotator cuff tears in general, is that often the tear size does not correlate with your symptoms. So I've had people walk into my office who are in terrible, terrible pain, who have just a little partial tear. So not even like this, maybe just the little edge of the tissue just sticking up, in terrible pain. And then you have other people who walk in the door who have full tears in their rotator cuff, almost 180 degrees around the top, and barely any pain. I have an interesting story about a guy. Maybe a year or two into practice, I saw this gentleman who was in his mid-80s, and he was in great shape. And he came in, and he said, I said, well, what's bothering you? How can I help you? And I said, are you having pain? No, I'm not having pain. What can I help you with? And he said, well, you see, on this arm, I can reach all the way up. And on this side, I can only get up to about here. And I said, okay, how's this affecting your life? Is this really ruining your life? And he said, well, I exercise all the time, and I do jumping jacks, and it's kind of bothering me that I can't get up there. And so I started backpedaling a little bit. I said, well, how did this start? Did you at one point have pain? Oh yeah, I had pain. He said, about 4 years ago, I did something, I fell and was painful for a while, but then it slowly got better. I said, well, were you able to lift your arm at all then? Geez, I had a really hard time doing it, but then as time went on, I exercised and it got better. So I looked at his x-rays, and it was clear to me that he had a big rotator cuff tear. And, excuse me, and I said, well, geez, it looks like you tore your rotator cuff, but you're not painful anymore. He goes, no, not painful. I said, well, this has gone on, oh, thank you. Appreciate it. This has gone on so long that, I don't think we could restore it. I go, but you've really already treated yourself here. I go, you without ever seeing a doctor, did physical therapy, and somehow were one of the lucky ones you got this thing pain-free. Now, granted, you're missing a couple degrees of motion, but you're doing pretty darn good. So it struck me as a situation where this guy had a big tear. When it's clear to see on x-ray, without even an MRI, this guy had a big tear, but he was lucky. He was pain-free. So again, the size doesn't always correlate with your symptoms, and then you'll get a patient who will come in, have a teeny little tear that you can barely see on MRI, and they come into your office and they're miserable, and they tried everything. They did all the therapy and all of the anti-inflammatories or injections, and it doesn't get better, and it needs surgery. So it's somewhat of a mystery who is going to get better ultimately with the lower level type treatments like physical therapy, and who eventually will need surgery. And that's why you have to sometimes just try. You try the lower, low risk type options first. So, excuse me. Let's go to the next slide. So my mom and dad are upholsterers. I won't plug their business because I said I had no financial disclosures. But anyhow, they're upholsterers, so it probably did influence my decision to become a surgeon. While I don't sew couches and chairs, I do sew tissues quite frequently. So this is one of my favorite slides, and it basically gets at the point that we were talking about, that tendon tissue is like fabric. It's not as thin as paper. It has actually a width to it and a substance to it. And that's why it can be difficult to get through to people why their tear might be different than someone else's. So imagine this piece of burlap having, a thickness, and imagine you somehow catching some of those fibers or wearing away the top half of those fibers. There's going to be a variation there between the new burlap that's straight off the roll and the one that may have been, used for a sack or a piece of clothing and having been worn for 20 years. So there's a difference there. And sometimes just regular friction over a long period of time can create a thinning of that fabric. And that ultimately will dictate how I may treat you if you quote unquote have a tear. So again, why is my tear different than my brother-in-law's tear? Well, it's because there's this thickness to the tissue. And is that fabric torn completely off of where it should be? Or is it merely partly worn away from having this low-level friction, but over the course of many years? Everybody's been to a stream and you pick up rocks, or you go to the ocean or the lake around here and you pick up rocks and you see how smooth they are. Well, one wave didn't create that smooth rock. It happened over many, many, many years and interactions, but it does happen, so it does wear. So there can be people who come into the office where it's just a pure wear phenomenon. That tissue over time wears or thins. And then there's other people who maybe fell off a ladder and the whole thing pulled off and like scissors straight through the burlap sack. Different entities, different problems. So, questions about that? Does that make sense to people?
If it's worn, is there anything you can do? If it's all the tissue's worn?
Yeah, there are things you can do. In fact, one of the things, the challenges of medicine is that we have to deal with the material that we're given. My mom and dad could order a new piece of burlap or a new piece of material or tell you which ones are going to last and you just replace it. But often we have to deal with the tissue that we're given. While we're replacing a lot of things, it's more of a challenge to replace these soft tissues. Sometimes just strengthening the tissues around it is enough. Sometimes if a surgery is necessary, merely smoothing out the rough edges is enough. Because if you have an intact tissue, just to get rid of some of these fibers, so think about these edges being frayed, imagine those kind of creating inflammation in a joint. Just trimming that and smoothing that away, sometimes that's enough. And so that'll dictate how different your rehabilitation might be. So that's why I tell patients when I go into surgery, if they get to that point, you say, look, this one looks like a partial tear in the MRI, maybe a small full tear, but it's hard to tell. And depending on what I have to do there, your rehab is going to be far different. Because if I just do some smoothing operation, you're going to be moving much quicker. And if I have to put some stitches in that to sew it up, I can't just send you back out into the world because we're dealing with human tissues. They have to be given a time to heal. That's, I guess, one advantage of being an upholsterer. As soon as you're done, you give it back. You can sit on the couch right away. So, next slide. So this is one of my favorite slides. How bad of a shoulder do you think that is? You see, first I should back up. This is an MRI. Okay, this is an MRI slice of a patient through their shoulder. Imagine the scanner sort of cutting your body in slices like this. That's through the shoulder joint itself. And then this is the MRI report read by your radiologist. Now, if you read that report, just looking at the amount of verbiage there, is that a good sign, do you think, or a not so good sign?
Not so good.
This is what I would think too. Agree? I would agree. Well, in actuality, that report is of a normal shoulder MRI. Okay, and that's why it's one of my favorite things. And this was an actual patient of mine.
Wow.
And what it gets to is this: that when you're dealing with a shoulder problem, MRIs can fool you. And I think we're seeing this more and more because I think it's a good thing, but people now have more access to their health records. Often patients are sent reports before we ever get to talk to them. But the downside to that is that you can get scared and say, let's see, The biceps tendon is intact, however, there is abnormal signal along the course of the superior labrum, posterior hiatus, blah, 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 blah. And you go on and on and on, and then your mind starts going crazy, and you start looking up every little thing on the internet, and you say, oh my God, next thing you know, you think your shoulder's gonna fall off. But this report is totally normal for someone of a certain age. That's the difference. And you have to take everything into context, which is why you sometimes have to get talked off the ledge about how bad it might be. But you also have to be careful that you're not jumping into invasive treatments too quickly either, because it could be easy to read that and think that, oh, it says I have 8 million problems, I've got to do something. Well, no, it's, believe me, you've got to put it all into context here, and that may just be totally normal for your age. Let's try and talk about this and see if there's a way of just getting you back to where you were before, because 2 weeks ago, before you started having shoulder problems, your shoulder looked exactly the same, but you were pain-free. So is there some way of getting you back to that state with an MRI that reads all of these things, or do you really need to address it? And sometimes we don't know. I mean, sometimes this is bad, but most times it's actually normal. And there are, if you went and MRI'd everyone's shoulder out on the street, I guarantee you'd find a lot of abnormalities, but nowhere near as many people who are actually having pain, which just goes to show that the human body has an amazing capability of coping and functioning as a complex system, and keep you going without minutely dissecting every single little detail. So it's a system. Remember, it's a system, and it's a complex system, and it works in conjunction, and you can't take out every little piece and expect it to work just like someone else's. Next, please. Good. So this kind of breaks down very basically some of the thought process of how we think of rotator cuff tears. And they fall into a number of categories, and it's going to actually dictate how I would treat one for you, or whether you may need quicker treatment, or whether you'd be more of a surgical candidate or that sort of thing. So let's talk about acute versus chronic, and this is a very important distinction. What is acute? So acute is the guy who is taking his window air conditioning unit out for the winter time, because that's about we're moving into that period where we're winterizing and it's not summer anymore, and he falls and lands right on his shoulder, and all of a sudden his shoulder's killing him and he can't lift his arm up. That's acute. Chronic. What's chronic? Well, exactly. Chronic would be, it's been bugging me for 2 months, 3 months. I didn't think much of it, and I was kind of hoping it was going away, and it's starting to get colder here, and it's starting to bother me more. I don't know, I just think I had to get it checked out. Did you ever have a fall or anything? Nah, nothing I can remember. That's chronic, where it's going on, and maybe 3 months is even, I wouldn't even call that chronic per se. I think if you looked at it from a more scientific standpoint, you're probably talking, beyond 4 or 5 months even, what you would call chronic. That is a big impact on how I look at a rotator cuff tear, how I would treat it, and how quickly or aggressively you may want to get into treatment. A general rule of thumb would be that chronic things you can approach more slowly. You can approach more conservatively, take your time with. And acute things you should be more aggressive with. And the simple reason for that is because when you have an acute tear, say for instance the example of the gentleman who was taking his air conditioner out and he fell. And he felt a pop. He felt a big snap. That's usually a circumstance where the muscle pulled completely off the bone, the tendon part pulled completely off the bone. When that happens, Leah, do you mind going back a couple slides? I just want to show this because I talk about this a lot in the clinic. Right here. So when that happens, in the worst scenarios, when it's a big tear, what happens is that these muscles back here, think of the red part, the muscle, acts like a spring and pulls the tendon back. And unlike a spring in everyday life where you can just pull it back and that's it, it's biological tissue. So the muscle, the tendon in here, it shortens and then scars up. And that will directly impact my ability as a surgeon to surgically repair a tendon. So if you have a lot of scar tissue and it shortens, you may just not have, oh, come on in, all right.
Sorry.
You may just not have enough tissue to deal with if you wanted to repair it. Oh, I apologize, we have a couple new guests. We're kind of halfway in the middle, but we were just talking about rotator cuff tears and problems, and we're at a point where we're talking about different categories. So we're talking about acute versus chronic, how that impacts our decision-making process and what we do for patients differently. The general gist being that acute tears we look at much differently than chronic tears. So again, acute tears, and I'm going to give away the take-home message here, but acute tears are the ones you should worry about, where one day you're doing great and you've never had a shoulder pain in your life, and the next day you feel a pop and you feel a snap and you can barely lift your arm and you're in miserable pain. That's when you should get in and see someone quickly, because there's a chance that you tore the tendon right off the bone and the clock starts ticking at that point. You may not have all the time in the world to get it repaired correctly, because as soon as you injure it, it starts to scar and shorten up. And maybe you get lucky. There's certainly plenty of people that I've seen this happen to where they waited a year for whatever reason, they just ignored it or didn't know, and we got lucky and the tissues were, like if you imagine this tear here, it's not a gigantic tear, maybe it stops right here and it doesn't shorten up. Well, then I've got enough to work with. But I see tears often that will retract all the way back here. And then you have to span a gap of a few inches sometimes, and that can be really challenging and difficult. So that's the one, the take-home message, the one thing I don't want you to forget, that if it's an all of a sudden sort of thing, a fall, a trauma, maybe a car accident, something like that, that's when you should worry. The chronic ones are different. Chronic, you've got time. And by that I mean, if it's taking you 6 months, a year, it's just kind of slowly nagging. I'm not saying you may not have a big tear, because it's certainly possible, but your body usually, those tears develop slowly over time. So it didn't, even if you have a big tear, it didn't happen overnight unless there was some kind of trauma. And those, there's a better chance that your body's going to somehow be able to adapt on its own. Whether it's through just physical therapy or other non-operative treatments. We can't always predict who you're going to be. I can't always, if I had patient A and patient B walk through the door and they both have the same looking rotator cuff tear and they both kind of happen slowly and chronically, one may respond fine to therapy, physical therapy, and one may eventually need surgery. It's hard for me to know which of those ones is going to work out that way. But at least you have that understanding. So let's go back to the, actually go back to the MRI. I just wanted, for our guests who came a little bit late, I just wanted to hit on a point here that's one of my favorite points, is that MRIs can fool you. And this whole report, this is a report of a normal MRI. And what I mentioned to the other folks here earlier was that if you looked at just the pure length of this report, you'd think, oh my God, this is probably the worst thing ever. There's so many abnormalities here. But a lot of it is age dependent. So it's going to be different for a person who's 55 or 60 than someone who's 20. So this may be a totally normal shoulder for someone who's 60 and maybe completely pain-free, but someone who's 20 may be far different. So it's easy to get caught up in all the details because the radiologists are paid to not miss anything. So if they see anything that looks somewhat abnormal, they're going to put it in the report. But without context, you could drive yourself crazy. So that's my take-home message for this slide. I didn't want that to get away from you, which is one reason why I don't blanket order MRIs on everybody, because I don't think it's necessary. I mean, a lot of the things you get from it, with a good physical exam and history, you really can figure out without the MRI. The MRI is a little more of a roadmap. So let's go back to here we go. Okay, so we talked a little about acute and chronic. I think it's one of the most important distinctions, and that I want you to take home with you. We talked a little earlier about full thickness and partial thickness, but I'll hammer that home again too. So think of the rotator cuff tendon as your fabric, which attaches the muscle to the bone. And it has a certain thickness. So just like this bag has a certain thickness. So one partial tear may be treated differently than another partial tear. Let's say, for instance, had someone come in and they've been hurting for 6 months and they're not getting better with physical therapy or maybe a cortisone injection. And we both decided, hey, this isn't getting better for you, maybe it's time to do an arthroscopic surgery. Well, the simple fact is that there are people who have just a tiny little bit of fraying or just a tiny little bit of tearing where maybe 90 to 95% of that tissue is okay and is still going to be maintained after that operation. And then there's people that are just hanging on by a thread. And those people I'm going to treat differently because if I just kind of smoothed out that one that was hanging on by a thread, maybe it's not enough tissue for that shoulder to get back to normal. And so in reality, you have to almost treat them like they were a full tear, where you just take those couple fibers that, hey, these aren't really doing anything for us, and you just complete those fibers, but you actually fix it with sutures, you augment it with sutures. So that's why it can be, again, confusing when you look and say, geez, my friend had this partial tear, and I don't know, he got doing rehab right away. He started, he was driving a car in a week, and how come you got me in a sling here and you're holding me up? What's going on? So you have to take it into context and push for details, because the details in this really matter. Full thickness, as we talked about, was basically if the whole tendon pulls right off of the bone. And then, but just saying one full thickness tear is maybe far different from another based on the number of tendons that are involved. Out of the 4 tendons, you may have part of one, or you may have 3 or 3.5. And it's a drastically different situation for those. Large and small, so that kind of gets into what I was just talking about there. I did, last week I did an operation on a guy who had a very small rotator cuff tear. It was about that big, a centimeter maybe. And then there was another operation a few weeks ago, which is a much bigger tear, probably 4 to 5 centimeters. Those 2 patients have far different outlooks in terms of both what we have to do from an operation standpoint and what their recovery may be like, and how quickly I'm willing to let them get back to normal because of the amount of work that you have to do. They also have different risk profiles. I mean, I can look at someone with a really teeny tiny tear and say, hey, you've got a really great chance once we've gone through this whole process of getting all of this back to normal and not ever re-tearing this. I mean, almost 80, 95% chance or better. With these big tears, it's a higher risk that they may re-tear or that the tendon actually doesn't heal. So we have to counsel people differently, and I think that's important. That's where the conversation comes in about looking at each one individually and talking to people about their different options. Let's go to the next slide. Good, so what determines whether one particular treatment might work well for you versus someone else? So it's clear that someone who's 40, athletic, their dominant arm, maybe they had a traumatic tear. There's a good example. A guy I treated a couple years ago was a softball player, tore his rotator cuff while he was landing for a catch. He was around 40 years old, very young to have a rotator cuff tear. That guy is a much different situation than someone who's 85, likes to play bridge, doesn't do a lot of heavy work, non-dominant arm. So we take all of these factors into play when we're talking about what to do for you. What's your job? Is it your right arm? Is it your left arm? How much lifting overhead do you do? I mean, there's a lot of people who just, most of their daily activities are from here down. And even if they're doing some stuff overhead, they say, I can tolerate, once in a while, just a little help, or it's not a big deal to me. Then you got a guy who's a painter, or puts up drywall for a living. I mean, that's his putting bread on the table. You've got to treat those people far differently. Age, some folks are retired. They say, if I was a couple years younger and I was working, I'd I definitely would have got something done, but I'm okay with it. I'm fine with it. Then there's other folks who, nowadays, older patients are a lot more active. I've got a guy who's 70 years old who does a lot of weightlifting, and he lifts overhead all the time. He's, although I guess the older everybody gets, the younger you get, right? 70's not so old anymore, that kind of thing. But I would venture to guess that everyone here would say if you're 70 and lifting heavy weights overhead, you're probably not the norm, But that's what he wants to do. So how do we take that into account when we're developing a treatment plan? I think it's important to do so regardless. We have to respect people's wishes and desires and how important it is to them, because just because you're 70 doesn't mean you absolutely have to give that up. So again, it really comes down to having that personal conversation. You come in the door and you can look up all you want online, and you can hear every story of all your friends and family, but in the end it comes down to what's important to you and what your needs are, and having an honest assessment with you and whoever it is you're seeing about those things, and then talking about, hey, look, here's the treatment, these are the risks with this treatment, but this might get you here a little faster, or that kind of thing. And there's a lot of different options. It's going to be different for different people. That's why with some people, having a full tear, if you're older and your demands are relatively low, sometimes they're not even worth fixing. It's not even worth doing an operation for. You may say, hey, let's just take care of some of the inflammation here, but get you comfortable, and you can do everything you want to do. But you get that guy who's a painter or the drywall, doing drywall every day. Hey, he's going to need some strength to get whatever he has to do overhead and do the work up in the ceiling. So, next slide. So my take-home message, which I hit on a little bit earlier, but I don't think we can hit on enough, is trauma. Acute injuries. When you have a circumstance like that, and say you fall or you get into a car accident and you go in the emergency room, and you did something to your shoulder, you felt a distinct pop, maybe somebody even heard a pop who was with you when you got injured. But you get there and they get a whole bunch of x-rays and all this stuff, and they say, your x-rays are good, you're clean. And you go home, they give you a sling, they give you a couple of pills, and they say, go follow up with your doctor. And you say, there's something wrong here. There's something wrong. This guy is full of garbage. Trust your instinct and get it checked out, and understand that there's more to the shoulder than just the bones, than just that ball and socket. That most of your shoulder is made up of those muscles and the soft tissues, and that you can have a tear there. And if you don't get it taken care of, you could potentially be setting yourself up for a situation where you may have a suboptimal outcome, simply because your body has already started to produce scar tissue, which may make that job of fixing it harder down the road. So that's my take home about that x-rays don't show you everything, and trust your instinct on that. If you don't feel right, that there may be something you can't see that's going on that might prompt your attention. So, next question. So I've got some bonus slides at the end if you want to see them, but I wanted to open up for questions now. I want to give everybody as much time as you want, and then if you want to hear a little bit more about some of the treatments, because I did touch on them, but I didn't show pictures. And if experience is any teacher, then people usually do like seeing some of the pictures of the different treatments. But because I was focusing strictly on, I wanted to give people a basic understanding of the confusing points of rotator cuff tears and what they are, I didn't emphasize the treatment so much, but I've got some extra slides. So why don't we go around and answer any questions, burning questions that you may have.
How long can inflammation last?
Well, that's a long time.
What's a long time?
I don't know if I have a definitive answer for you. I mean, the way I'd put it is this, that if your shoulder is quote unquote out of balance, that if there are muscles that aren't functioning normally, theoretically you could have inflammation forever. I mean, if you have a certain amount of weakness or a loss of strength that is not correcting, then you could get some chronic irritation in certain parts of the shoulder. And the shoulder's very complicated. There's more than one joint there. It's not just that ball and socket joint. There's a joint between the collarbone and the shoulder blade that we call the AC joint. There's the ball and socket joint, which we call the glenohumeral joint. There's technically a joint between the shoulder blade and your chest wall. It's not the usual type of joint that we think of like your knee or hip, but in reality, your shoulder blade glides across it. So there are areas there that can get irritated. And there's also a joint where your collarbone connects to your sternum. So in all of those places, there's a potential for inflammation, irritation, if the other pieces aren't functioning well, because you've got abnormal mechanics. And that's what we try to address with therapy. That if we can, we get the other muscles around the shoulder that are supporting it to guide you back into more normal muscle patterns, and then hopefully reduce the inflammation. Now sometimes there's a structural problem that won't let the inflammation go away. I mean, there's a tear in your bicep tendon in your shoulder, or a tear in your rotator cuff, or cartilage damage, or something. There's a myriad of reasons. And so if that problem, like the pebble in your shoe, that you don't get the pebble out of the shoe, the irritation never goes away, it can be like that. So the short answer is, if it's the wrong problem, indefinitely. I mean, arthritis. If you think about what arthritis is, it's where your joint surface wears away. So you've gone from a surface that's very smooth to now bone on bone, very rough. That irritation won't go away, and your body's natural react, unless you do something about it, whether it's a medicine or surgery or some kind of corrective measure. Your body's natural mechanism is to produce inflammation, because then at its core there's a purpose to inflammation. It's, if you think of like a blister, the problem isn't the blister, it's the whatever irritated your skin to cause that blister, and then your body's reaction is to bring the healing cells and elements to that area. It's just that when it gets out of kilter, when that the healing mechanism is more than we can cope with, because it's a constant irritation. So hopefully that answers your question.
Well, you think of the blister healing itself.
Right.
No, the blister. So does your inflammation and your tendons ever get together again without surgery? Does the new blood get in there and start to healing like a blister heals itself?
Right. So the example of the blister isn't the greatest, because often it goes away. But imagine an area where there's a blister that continues to get irritated.
Right. Okay.
It
stays red. And it
right.
kind of stays
Correct.
thin looking.
So you have to then you've got to look deeper and say, well, what is irritating this? So is there a tear that's causing continued inflammation? Is there something else structural, or is it a muscle imbalance problem? Is it that you're slightly relatively weak in one spot but stronger in another spot, and it's causing an abnormal motion in the shoulder that's causing irritation? So it's figuring out where that irritation is coming from within some level of confidence. And some do get better. There are people who have partial tears that get temporarily inflamed, or a bursitis, where it's an inflammation around the tissues between the rotator cuff muscles, and eventually it goes away. Sometimes we can understand why, and sometimes we can't. Other questions? Yes?
You walk into your doctor's office and you say, my shoulder hurts.
Mm-hmm.
Can they just tell from feeling things that, yeah, it's the rotator cuff? Or is it just a good guess? Or what do they have to do first? Before we would...
Yeah. Do you mean...
My primary.
Oh, if you go to primary. Well, I guess it just depends on the person. Yeah.
Okay.
It depends on how... There are primary care doctors who deal a lot more with musculoskeletal issues. And for instance, we have on staff a few non-operative doctors who are family medicine doctors first, and then did extra training in musculoskeletal health. So I think their experience and their training dictates how comfortable they are with diagnosing those things. And then there are others who are much more skilled in other areas, like things that I don't know as much about, like diabetes and heart disease and things like that. And it really depends on the doctor. They may have a very general understanding and say, yeah, it's probably this. And it really, it's very dependent. You'd have to, I would encourage people to talk to their own primary care doctor and say, look, how comfortable are you, with these problems? And they should give you honest answers. I mean, my general guess is that most of them are very facile with all of the bread and butter basics of, things that, like heart disease, et cetera, all the other systems. They really have a lot more on their plate than we do in some ways, because we have the luxury of being able to specialize and hone in certain areas. So I think it's variable. Other questions?
Can the pain, I've been having an issue, so,
Mhm.
and I've never thought about at first I was just having like soreness in this muscle, and I was going to a physical therapist for something else, and he took me through well then it started to get worse.
Mhm.
So he took me through some motions with the arm and said that, it's either bursitis, tendonitis, he doesn't really know
Right.
what it is. But doing the physical therapy, it's getting worse. And now I'm getting like a pain up into this side of my neck as well. And I know you're not here to diagnose anything, but I don't know, any thoughts?
Well, yeah, I have to, of course, say the disclaimer that we can't treat you right here. I can talk in generalities. I can tell you that all of those muscles are connected. So from your neck on into your shoulder, they form what we call the shoulder girdle. So it's not uncommon to get patients who have either a shoulder problem that then radiates up into the neck, or a neck problem that radiates down into the shoulder. It's not uncommon. What I can say in general is that if we use a lot of words interchangeably, such as tendonitis, bursitis, even partial thickness rotator cuff tears. Often they act very similar, and it's more important for me often to know how quickly or slowly the problem developed and where it is, to start on a general physical therapy program. So again, if they start slowly, I tend to start treating them with a slower method, with physical therapy, for instance. Yeah, you'd want to know, I don't know, you'd want to try and get at a diagnosis before you start a physical therapy program in some way, just to, and the therapists here are, and I don't just mean our practice, but I mean in general in this area, are very good. In fact, if I'm not mistaken, I think people can go to therapists without ever seeing a physician first, if I'm not mistaken, but don't quote me on that. But the therapists are often, who deal with shoulders, are often very skilled in having at least a general idea of what's going on. I think from my perspective, you can break down problems into a few categories like we did up there with the rotator cuffs, but you can talk about shoulder stiffness. So is the joint stiff or not? And the therapists are usually pretty good about telling that. Is the joint rough or not? So do you have arthritis where you're getting grinding? Is the joint weak or not? Is it inflamed or not? So those are basic parameters that you can look at. But certainly if you're not getting progression with physical therapy, then it may be you may want to go to that next level to really get to the bottom of it. Because it's true, a lot of things do get better on their own or with gentle therapy, but if they're not, or they're getting worse, then that should tell you something. Trust your instincts with that. Other questions?
I'd like to see the rest of the slide.
Oh, sure. Okay, good. Yeah, I put up some slides of treatments. And I know I peripherally mentioned various treatment options. So on the left hand of this slide, I put in the low risk or non-operative. And for me, they fall into three basic categories: pills, shots, and therapy.
In that order?
No, not in that order. In fact, I actually don't prescribe a lot of medicine, mostly because people can either get it over the counter. They've often already tried it themselves. I've been recommending some now that I've had some success with personally, that I've been telling people about. I don't know how deep I want to get into it here. But turmeric, there you go. See, she said it. I found that to be very, very helpful. In fact, half my patients already know about it. So, and I don't remember where I first learned about it, but there's something to it.
It's everywhere.
Yeah. But we found, I pulled the literature on it, and we found that there's definitely a natural anti-inflammatory effect. So I've been recommending that. But yeah, we start there. Injections, I think there's a very limited role for them. You'll hear a rule thrown out there, and people will say, well, I'm not supposed to get more than 3 per year. And in reality, there's no hard and fast rule. I think where that number came out is that medicine, cortisone, which we often use around the shoulder or other joints, hangs around in that area for a few months. And so the idea is that we don't want to give too much of it. The other reason is that it can actually have a detrimental effect on the tendon in time. So if you give too much, it can wear your tendons, degenerate your tendons. What is too much, we don't exactly know, but that's why I use it on a relatively limited basis, usually only for people who are in so much pain that they may have difficulty doing therapy, or you're really trying to get them through a rough patch, or they may not qualify for a surgery. For instance, someone who's just too unhealthy or something like that. But because there is a downside to it, I'm tempered about it. Therapy is very, very common. We use it all the time, and you can actually do wonders with it, I think. It's super low risk. I mean, your body will tell you whether it's working or not. And it's basically trying to get your shoulder girdle muscles to function in sequence again and to strengthen in hopes that the body gets rid of the inflammation on its own. Surgery, the picture I put up here for surgery, that falls into all different categories, but this is just a general schematic of what we call arthroscopic surgery. And I think people are pretty aware nowadays that there's many types of minimally invasive, whether it's laparoscopic or arthroscopic. For us, it's arthroscopic, which basically just means scope and joint. But we're able to do quite a bit of activity with little incisions this big. Go to the next slide, because I think I have it on the next slide. So yeah, I like putting this one up. It's like building a ship in a bottle. You wonder how they are able to do that. But basically, it's been an evolution in technology. Instruments that allow us to do the same things that used to be done open, or sometimes are, now through tiny little incisions, which I think there is a real role for it. And I certainly trained in the era of arthroscopy, so it was a regular part of my own training, and then I did advanced training in it too. So it's a very, very common part of my practice, and I would say more than 95% of the rotator cuff problems I'm handling these days are arthroscopic. There's still a place for open surgery, and I still do use it, and sometimes it just makes sense, but certainly able to pick and choose what those circumstances are. So I go to the next one, we'll show some pictures of, so these are some of the instruments, and I guess what you notice about most of them are that there's some variation on a kind of a scissor where there's a long handle to the instrument, and what you see at the end are maybe little biters or little different, each of them has a different function at the end, but you'll notice how they've got a long handle, and you can imagine building that ship in a bottle, except we're doing it with inside joints. So it does take a long time to become facile with it, and there's definitely some unique skills involved, but it's not going away for sure, because there's things that we can do with it that we couldn't do years ago. There's actually some operations that are much easier doing that way because of the structures that you have to maneuver around than doing it in an open way with bigger incisions. So not just the small incision. I have to get on my soapbox a little bit too, though, because I think some people confuse the fact that if you're doing something arthroscopic, the assumption is that automatically it's better, and that's not necessarily the case. You should always worry about what's being done deep down, where the problem is, and sometimes it's better done open. The other thing is that the assumption may be that just because it's small incisions, it's less trauma or less work. In reality, what's going to dictate your rehabilitation will be what was done down deep. So whether I did a rotator cuff repair open or arthroscopic, if I'm putting sutures in there to hold it together, I'm still going to then require you over time to have some limitation in that early postoperative period. It's not that, oh, I did little incision and now you just get moving right away. No, what's going to dictate your rehab course is going to be what we did to fix the problem down deep. So that's my public service announcement. So I don't think there are any more slides there. Check and see. I think that was the last one, right? Yeah, that was my last one. So, are there other questions? Yes, sir.
In a tear, is the tendon is attached to the bone, correct?
Mm-hmm.
So if there's a tear, part of the tendon is still attached, and there's a tear in between where it connects to the muscle. How often is it actually detached from the bone? And what happens?
So I guess what you're asking is, out of rotator cuff tears, how many of them are what we would call full thickness, where it truly detaches?
Yeah, right, detached right from the bone?
Yeah.
Yeah.
I don't know if I could answer a number right off the top of my head for you. I could tell you that certainly partial tears, tears within the tendon itself, and small tears make up the majority, probably more than 70 to 80%. Small full tears, I should say. There's an interesting study done years ago on people who had no shoulder pain. So there was a surgeon who was the chairman where I trained, but he had moved on years before. This was done, I think, in the 60s, where he literally went and asked permission of patients who were dying to examine their shoulders after they had passed away, to dissect their shoulders. And so he then got their history and asked them, did they have shoulder pain, did they not have shoulder pain? And then after they passed away, he was able to dissect and figure out whether there was a tear in the rotator cuff or not. And what he found in that patient population was the rate of full tears was somewhere in the range of 35% of people who didn't even ever report shoulder pain. So when you ask how common, what we're seeing is through a certain lens, and that lens is the people who had pain, who came to an office, got examined, got an MRI, went to surgery, all those things. So what is the true incidence? Not entirely sure, but I'd venture to guess, if I had to roughly guess, I'd say out of all of them, there's, partial tears are very common. Small full thickness tears, out of the full thickness tears, probably occupy somewhere in the 60 to 70% range, and then you say medium and large kind of follow a shrinking distribution from there. So, other questions? Feel free, don't be bashful.
What's the success rate of a partial when you have to do the surgery?
Success rate of a partial is usually very good, greater than 90 to 95%. And I would put that too with small full thickness tears. In other words, it not coming back. Primarily because if it's a partial tear, and again, it depends on whether it's a large partial tear or small partial tear. Small partial tears, you can often get away with just smoothing them out, recontouring back to normal tissue. If you have a large partial tear that maybe occupies more than half of the thickness of that fabric of that tissue, then you may be dealing with a full repair where you put some stitches through it. Again, I think it's still a very high success rate because even small full thickness rotator cuff tears have over a 90 to 95% success rate. The chance of a tear coming back or re-tearing after a surgery is directly proportional to the size of the tear. So the larger the tear, the more likely it is to, at some point, fail. It's not to say that all the ones that fail actually become painful. They've done studies on this too. That's why it makes the whole thing is somewhat mysterious. There are people who have surgeries, repairs, and then MRIs or ultrasounds that show that their tear didn't completely heal or retore that are pain-free. So it's actually interesting, very, very interesting topic that people continue to debate and mull over. So.
But when you do the surgery, people are going back to their regular activities usually, or is there any limitation after the surgery?
Within what time frame?
No,
After the full time frame, you mean? Yeah, the goal is to get them back to whatever they're doing. Now, if for whatever reason, say it was a very difficult circumstance, and depending on job demands, et cetera, there may be cases where, and those are usually the more extreme cases, where you say, geez, you probably shouldn't be doing that overhead type job anymore because your tear wasn't repairable. But assuming it was repairable and it was a problem that's solvable, then yeah, people usually go back to do what they did before. I mean, often better simply because they aren't dealing with the pain. But yes, sir.
You probably said it, I'm sorry if I missed it.
Sure, no problem.
If you don't do stitches, how do you repair a tear?
So we typically, if we're repairing them, so if it's a full tear that we are actually repairing, that is with sutures, pretty much 100% of the time. The fixes, quote unquote, that we're fixing, but not maybe. I guess it all comes down to how you use the word repair. So when I'm using the word repair, that usually implies that I'm putting stitches in. You can fix tears sometimes that are frayed, that have a rough edge, by using small shavers. So this picture doesn't show it, but there are tiny shavers that are a few millimeters that.
So you shave the bone?
You shave the ends of the tissue. So go back. Can you go back all the way to that fabric one? I don't know if you saw that one slide, but
Yeah.
so if you think of this as a frayed edge, sometimes all you have to do is trim the frayed edges back to more normal tissue. Sometimes that's enough.
Oh, okay.
Yeah.
Because they're interfering?
Sometimes they're rubbing in different areas, causing inflammation. And sometimes it's not the rotator cuff too. There's other things that we only hit on rotator cuff problems, but there's biceps problems, there's AC joint problems, there's labrum problems, there's arthritis problems. So there's other problems that may be going on at the same time. But that being said, if we're not putting stitches in it, it would usually be shaving frayed edges of tissue. That's typically, or sometimes loosening it up. Removing some scar tissue that allows the shoulder to mobilize better, to move better.
Thank you.
okay, when you have the MRI done,
Yes.
and you have your shoulder, do they look at the other parts that you just mentioned, that you said it could be other parts of your shoulder?
Yes, with some, you have to understand that MRI is not perfect, and that some types of MRIs, namely whether you put dye into the shoulder or don't, will be more detailed or less detailed. So the rule of thumb is that if you don't have dye in the shoulder, it is not as exact if you're looking at what we call the labrum. That's this rubbery type washer. I didn't show any pictures of it here, but you may miss certain things with that. So yeah, it just depends on what you're looking for. But the MRI scans are very good these days, and often, if you're seeing a specialist, they can usually narrow it down without even an MRI scan. I mean, in my practice, MRIs are usually just for either confirmation or for planning for surgery. Less likely that it's purely diagnostic, because you can get a lot of information from your story, your physical exam, your story and your physical exam, I should say. You get a tremendous amount of information. Yes?
Supposedly have a separated AC joint,
Mhm.
but the pain is going down here. Could that possibly be something other than the AC joint? I had the MRI done, but I haven't got the results yet.
Again, I'll speak in general about it. In general, when you have an injury to the shoulder, like an AC separation, it's not to say that you can't get other injuries at the same time. So it'd be important for you to see someone who could examine your shoulder and figure out, when I examine a shoulder, I look at multiple different parts of the shoulder, and I try and focus on which of these many pieces is causing your particular pain. And so what you need is someone to go through, and depending on how long you've had an injury, where the pain is coming from. I've certainly had patients who have AC injuries who also have other issues going on in the shoulder. So it's not to say you can't injure it in more than one way. I've had ones with AC injuries and labrum injuries, or depending on the age, AC injuries and rotator cuff injuries. So that it'll guide you, but it's important to have someone actually hone in on that for you. Yes?
With a person who has chronic pain, like, me, this has gone on for a long time. Say it is the rotator cuff and you did surgery. What's the percentage of people that would end up having like that would have to have the other shoulder done as well? Because right now,
it's difficult to tell unless I know exactly what is going on, but I can tell you in general, people with rotator cuff problems on one shoulder, it is more likely to get it on the other shoulder. So they've done studies where they look at a group of 100 patients, and one of the risk factors of getting a rotator cuff problem is the fact that you had one on the other side. So it tells us that there's something genetic, that there's something there. It's definitely that way with arthritis as well. So if, say, someone's problem was not rotator cuff, most people I see with shoulder arthritis have it on both sides. Again, something genetic about it, something, so those two things certainly do show up on both sides. It's not a guarantee that it will, and everybody's case is different. Other questions?
So you keep talking about patients, and I see your office here on Harlem Road.
Yes.
So you are a regular operating office that we could call and make an appointment?
Yeah, in fact, we should have a whole list of cards here for you.
Yeah, I got one over here.
And you can call our office and make an appointment. And in fact, my secretary is here today, and she'd be happy to
Just call tomorrow if you want to get in, absolutely.
Yep, and we've got a pretty open schedule because I just moved to town a couple months ago, so.
Well, how come?
Yes. I moved from Ohio, and but I've been in practice for 7 years, so I'm not new to the area, not new to the field. So, but no, I enjoy doing these talks actually because I found that, and this is the honest truth, the people that I've had who've come from these types of venues are usually some of the most informed patients, and we usually have a great opportunity to connect before they ever come to the office, and I don't know, it just seems like a very good group of people that, people who take ownership of their health always do the best, regardless of what it is that they have. It's an X factor that you can't really put a price tag on.